Hi, my name is Elad Anter, and the title of my presentation is What is the optimal method for substrate mapping of scar-related VT, results of LV activation from multiple directions. I am presenting this study on behalf of my colleagues from Boston, New York, Prague, and Seoul, and following this presentation, the full manuscript will be available at the Circulation, Arrhythmia, and Electrophysiology website. Re-entry usually occurs due to local heterogeneity in both conduction and recovery. In scar-related VT, this is caused by non-uniform anisotropic conduction, source-sink mismatch, and electrotonic coupling between cardiomyocytes and replacing myofibroblasts. VT rarely starts during sinus rhythm, but is often dependent on premature beats that interact with the infarct from specific directions and usually at a specific coupling interval window. In this beautiful study by Gil Jansen and Jacques de Backer, one can note that activation of the scar from one direction leads to minimal conduction delay. However, activation of the scar from a different direction leads to significant slowing and block. The results of this study and other studies illustrate the importance of the direction of LV activation on the ability to identify areas of slowing. We also know that the VT isthmus often co-localizes to sites exhibiting activation slowing during sinus rhythm. Moreover, these sites can serve as anchors for multiple VTs in the same heart. Therefore, they can be referred as re-entry vulnerable zones. In this figure, from a study we published nearly 2 years ago, one can see that the area of maximal activation slowing during sinus rhythm serves as an anchor for multiple VT configurations and cycle lengths in the same heart. However, there are several questions that remain unsettled. 1. Is activation slowing during sinus rhythm sufficiently sensitive to identify all potential isthmus sites, or can these only be revealed by stimulation from different directions and potentially at different cycle length? 2. Does selective ablation at sites of activation slowing, as delineated by directional differences in activation during sinus rhythm and ventricular pacing, can improve the results of ablation in patients with scar-related VT? To answer some of these questions, we performed a prospective multi-center study. Patients with infarct-related VT were mapped using either Rhythmia or Carto3 and multi-electrode mapping catheters during atrial, right, and left ventricular pacing at a cycle length of 600 milliseconds. Each map was analyzed individually, and the areas of maximal activation slowing were marked on the map. This was defined objectively as activation velocity lower than 40 milliseconds per 10 mm distance at the vector of propagation. Ablation was applied to the cumulative area of slow activation defined as the sum of all regions with activation times greater than 40 milliseconds per 10 mm. The primary outcome was the composite of appropriate ICD therapies and cardiovascular death. 85 patients were enrolled in 3 centers. The follow-up duration was relatively long with a median of 3.6 years. The LV was mapped from a mean of 2.4 directions. The mean age of the patient was 67. 42% of the patient had history of CABG. The left ventricular ejection fraction was 31%. 13% of the patient presented in VT storm, and most patients failed therapy with amiodarone. Endocardial activation slowing was identified in most patients. The distribution of maximal activation slowing was dependent on the direction of LV activation. The overlap in the area of maximal activation slowing between sinus rhythm and RV pacing was 84%. Between sinus rhythm and LV pacing was only 61%, and between RV and LV pacing was 71%. EGMs in the area of maximal slowing often exhibited multi-component potentials, usually within the QRS, consistent with the definition of LAVA. However, EGMs beyond the area of maximal slowing often exhibited double potentials and late potentials. This is an example of a patient with anterior wall infarction. The left panel shows activation during atrial pacing, the middle panel shows activation during RV pacing, and the right panel shows activation during left lateral pacing. Note that while the general area of slowing is similar, the precise location, size, and magnitude differ significantly. In particular, activation from sites closer to the scar, such as during RV pacing, results in larger area and magnitude of slowing. Activation laterally to the scar results in shifting of the area of activation slowing more laterally. Electrograms in the area of maximal slowing often exhibit multi-component potentials within the QRS. These are the corresponding voltage maps. Note that the areas of maximal activation slowings often corresponded to the sites where the wavefront first interacts with the infarct. This particular patient had multiple VTs, and none of them were hemodynamically tolerated. In one of those VTs, with a tachycardia cycle length of 224 milliseconds, the isthmus and the site of VT termination with ablation corresponded to the region of maximal activation slowing identified during lateral LV activation, but not during sinus rhythm or RV pacing. 86% of the mapped VTs, the isthmus corresponded to the summated area of activation slowing as identified during LV activation for multiple directions. In contrast, only 58.3% isthmus sites were localized to sites of maximal activation slowing during sinus rhythm. This is the central illustration. It shows that the area of maximal activation slowing is dynamic, and it's influenced by the direction of LV activation. The area of maximal slowing will occur at the site where the wavefront first interacts with the infarct. So what are the implications for ablation? Ablation of the summated area of activation slowing as identified by LV activation from multiple directions resulted in a reduced VT recurrence rate compared to patients who underwent ablation guided by activation slowing in sinus rhythm alone. In conclusion, the direction of LV activation influenced the location of activation slowing. Mapping during sinus rhythm identified 70% of the total area of activation slowing as determined by activation from multiple directions, including atrial, LV, and RV pacing. The area of maximal activation slowing corresponded to the side where the wavefront first interacted with the infarct, usually the bipolar voltage amplitude below 0.5 millivolts. Selective ablation at the cumulative area of activation slowing is determined by LV activation from multiple directions, resulted in a lower rate of VT recurrence compared to selective ablation at a site exhibiting activation slowing during sinus rhythm alone. Mapping algorithms and workflows for creating activation maps simultaneously from different directions may be helpful in improving the sensitivity and specificity of mapping. Thank you very much.